Hi, my name is Jessica Hunter, and this is Module 8 Signature Assignment. Today we are going to be discussing a clinical problem that we will implement into the practice and try and change in the clinical environment. On March 11th, the world went into a global pandemic. As the numbers of cases rise from the coronavirus, political leaders encourage social distancing to decrease the transmission of disease, but healthcare also suffered from a shortage of personal protective equipment. Working in a hospital already, I myself have already had the consequences of lack of PPE with reusing a N95 and calling down to the maintenance or supplier for personal protective. We've had to use other methods of personal protective, like using disposable scrubs versus using drapes, like typical PPE is worn. This shortage poses issues for healthcare workers and their protection for caring for patients with the coronavirus. Different hospitals are implementing different types of sanitation for devices such as N95s. Currently, they are looking into UV for sanitation. Since we are 6 months into the pandemic now, there is scarce resources and scarce research that is available because this is a new problem and a global pandemic. As numbers are rising, there is becoming more need for proper PPE. When conducting my own research, I found that it was very difficult to find the most updated information to how they are addressing this. A lot of it was sources saying what techniques they are using and trial runs for proper sanitation. As a healthcare worker, in my own experience, when the CDC first came out with the guidelines and we were first getting COVID patients, we had to come onto the unit, and all we were using at that time was just surgical masks. There was a lack of N95, and this posed a problem. And workers on the unit who are more at risk were considering not coming in due to this lack of PPE. So describe how you intend to operationalize the practice change in your practice environment. Well, I think there needs to be access of proper PPE, and hospital policy definitely needs to not admit patients if we don't have a proper PPE. So I advise that for unit and unit managers that we should have at least 2 weeks of proper PPE per patient that comes in. That way we know the healthcare workers that are caring for these patients won't have to stretch their PPE or reuse, which can be dangerous to the healthcare workers. Any suspected cases of coronavirus or anyone who is at risk of exposure should be using a N95 respirator mask. According to the CDC, there is additional guidelines for a one-time use respirator mask. If the depletion of this stock is down, then the use of a scarf, bandana, or homemade paper cloth mask is recommended. But the evidence for this is thin. As I was saying before, research for using cloth masks versus medical grade masks is very scarce right now, as we are still currently in the global pandemic. For optimizing PPE use, I think that we should utilize UV sterilization and send unit budgeting towards sterilization tools so that we can properly reuse PPE since there is a shortage. What theoretical models will you use and how will you overcome barriers to implement them? So I think a good theory model would be a qualitative research theory so that we could use like a questionnaire to discuss with the nurses and the medical staff on the unit how to best approach the lack of PPE and see what the healthcare staff understanding and how they would like to approach it. I think communication is very important in times of shortage for medical supply. In Tokyo, Japan, they created an online questionnaire that was implemented using Google Forms. The link questionnaire was sent to members of the Tokyo Medical Association back in April. Due to the limited amount of PPE available for donation registration, it was limited to 125 back facilities on a first-come, first basis. The survey was conducted, and the total number of patients with COVID was 9,845 during this time. This questionnaire was used as a source to understand how the PPE shortage was affecting Japan's healthcare system. By globally understanding the shortage of PPE, we can apply that to our own units here in the United States, especially in Arizona, as numbers are rising for COVID cases. A quantitative theoretical model can be used after the appropriate information from the questionnaires have been reached, because we understand how much PPE that we do have in the United States, and we can distribute those accordingly for patients and prioritize which PPE or how we will use the PPE on the unit. What source of internet evidence will you use in providing data to demonstrate improvements in outcomes? There's a use of smart software and networking with various distribution channels to meet shortfall in PPE and infectious prevention control methods. PPE in healthcare includes gloves, aprons, long sleeve gowns, goggles, fluid repellent, surgical masks, eye and nose and mouth protection, face visors, respirator masks. Healthcare workers should be wearing protective clothing when at risk. During the current pandemic, there is a particular focus on airborne droplets because these can be expelled through breathing, sneezing, or coughing from an infected COVID patient, which may travel many, many meters and survive on surfaces for potentially several days. The use of smart softwares and technology can help demonstrate the improvement in outcome and in patient care, and in the outcome of protecting our healthcare workers. Many units are using methods such as vaporized hydroperoxide, UV technologies, which can delay the spread of the virus and help clean protective equipment. So methods for improving outcomes is finding different sterilization methods for reusing PPE and properly admitting patients with the right amount of PPE, for example, of having enough PPE for 2 weeks for one patient hospital stay, and ensuring proper methods and access to the PPE that is in the hospital. Are there any ethical considerations? The ethical considerations for the issue of shortage of PPE could be considered the reuse of PPE. This can be an ethical issue, or just distributing only minimal PPE. In the beginning of the pandemic, we were not aware of what kind of PPE that we needed for COVID-19. At this current moment, there is more research developed, and more is developing as we address this global pandemic. But I definitely believe that an ethical concern is the use of PPE and how fast we can massively produce enough for the care and for the rising numbers of COVID patients. The current guidance from the U.S. Occupational Safety and Health Administration Agency of the U.S. States Department of Labor states that healthcare workers must use proper PPE when exposed to a patient confirmed or suspected with COVID-19 or other sources of COVID-19. Not having the proper PPE may put the patient at risk, the EMS at risk, the community at risk. The decrease in PPE will decrease in positive patient outcomes. It is important that nurses develop that they ensure their own personal safety and safety of others when delivering care. Good practices involve minimalization of risk and compromising any patient care and reducing risks. Thank you for listening to my TED Talk.